Good afternoon, everyone. First of all, I would like to thank all the organizers and Koicho chairperson to giving me this great opportunity to present our data. My name is Koicho Ono. I work in Nippon Kokan Hospital located in Kawasaki, Japan. The title of my talk is Micro-endoscopic discectomy for extraforaminal lumbar disc herniation, comparing micro-endoscopic discectomy and percutaneous endoscopic lumbar discectomy, PELD. Note that in Japan we call the tubular assisted surgery as MED. So the extraforaminal lumbar disc herniation, ELDH, occurs in 7 to 12% of lumbar disc herniations. As you know, ELDH is associated with severe pain caused by direct compression on the nerve root and dorsal root ganglion. The posterolateral approach, shown in the blue arrow, provides minimally invasive access compared to posterior approach, shown in the red arrow, and can preserve the spinal instability. Endoscopy is a good indication for the posterolateral approach. MED and PELD both have been reported to have a favorable clinical outcomes. However, comparisons between these surgery for ELDH has not been reported. So the aim of this study was to compare the clinical outcomes and complications between MED and PELD. 33 patients with ELDH who were treated by microendoscopic surgery from 2006 to 2013 were retrospectively investigated. Before June 2012, all the patients were treated by MED. And after June 2012, PELD was performed, except for those with L5S1 ELDH. They were treated by MED. There was no difference in the sex, age, or follow-up period between the groups. The parameters listed on this slide were compared between MED and PELD. Surgical time was shorter in a PELD group compared to the MED group. Because PELD directly starts from the discectomy, approaching time of PELD was 0. And on the right, the duration of the discectomy was significantly longer in the PELD group than in the MED group. But if you average out the total length of the surgery, PELD needed a shorter time. The postoperative WBC and CPK elevation and CRP level were all significantly lower in the PELD group compared to the MED group. From these data, we can appreciate the fact that the PELD is less invasive. The incidence of suppository use and exiting nerve root injury were similar between MED and PELD. So let me show you the examples. First, MED case. We had 41 years old male with L5S1 ELDH. This is a video of the case. During the approach, we need to cope with soft tissues, and usually drilling is necessary. And we retract the nerve root, and the herniation can be resected. The total length of the surgery was 125 minutes, and JOA recovery rate for this patient was 100%. Next, PELD case. We had 49 years old male with L3-4 ELDH. You can see the large herniation on the right. This is a video of the case. PELD starts from intradiscal space. Discectomy is first done intradiscally, and then turn the cannula to locate the herniation. And the large fragment of this herniation was grasped and removed with an endoscope. After the removal, we can observe the decompression of the nerve root. This herniation was removed, and the JOA recovery rate was 94.1%. After the surgery, the hospital stay was shorter in the PELD patients than MED patients, whereas the clinical outcomes were equal between the groups. So according to our results, the surgical burden of PELD was smaller compared to the MED. Importantly, clinical outcomes came out to be unequal between these two surgeries. Thus, our results may suggest that if the surgeon have acquired the technique, the PELD is recommended for ELDH. In MED, a surgeon needs to cope with soft tissues before the discectomy. This is a very, very stressful steps during the surgery, and it takes more than half of the total time. However, once the disc is exposed, retracting the existing nerve root and discectomy are relatively easier compared with MED. Sorry, PELD. In PELD, endoscopy starts from the inside the discal space. So therefore, the surgeon does not have a stressful approach. However, in our study, 6 out of 16 patients experienced irritation after the surgery. All of them recovered by the final follow-up, but we need to be extremely careful not to retract, push, or retract or push or exiting nerve roots too strongly. In conclusion, PELD is less invasive than MED for ELDH removal. PELD and MED are promising treatment. However, we need to very careful about the exiting nerve root. In the future, we will apply the PELD on L5S1 herniation, and additionally, to perform PELD more easily and safely, we need to develop new devices. Thank you very much.